Okay, so reloaded Infirmary, and we're going to make a few other on-the-fly simulations just to show you and highlight some of the features of Infirmary. So as I showed you in the last segment, we had a cardiac monitor, a defibrillator, and a 12-lead EKG open all at the same time, modeling and affecting the same patient. We had the defibrillator sending pacemaker spikes. We had the patient with a responsive QRS complex to every pacemaker spike because it was capturing. And then we even showed the 12-lead EKG with all those different changes. So I do want to show some of the extensibility of the cardiac monitor. To start with, the devices themselves, they do have different options. So every device has the option to be paused, to unpause, to add numerics, and to add tracings. Numerics are just what I called the vital sign number parameters. They're a numeric output, a number, as opposed to these tracings and waveforms. Some other options in the cardiac monitor are to enable and disable alarms and a color scheme for either a light color, white on black, or the dark with multicolored colors for different parameters, similar to most of the cardiac monitors on the market. Some other options, as you've noticed probably by now, the patient editor and the actual simulated devices open in separate windows. So the reason for that is if you have a sim lab where there's a control station inside the control room, the patient editor would be what you want on the control room screen. But you could also have a monitor, a second monitor attached to the computer that's running this, and you could send the cardiac monitor to that physical monitor in the simulation bay. So in that way, we can have a single computer with multiple displays running Infirmary and propagating any changes that you make to the patient editor to the actual simulation that you're running. So some changes that you need to be on the actual computer for, like with a mouse to be able to change, are to add and remove tracings. So I'm going to add some tracings, and there are some default tracings that do show up in order. So suddenly this cardiac monitor is becoming a bit more complex. It was showing 2 leads of the EKG and a pulse ox. Now we have the respiratory rate turned on. We have end tidal capnography. And this is where some of our more advanced parameters start to show up in the patient model and in the devices. So if I open up the respiratory profile, I can adjust the I to E ratio, which will affect how the end tidal tracings show up. So I'm just going to start affecting that, and those changes will start to propagate into the monitor shortly. I can also change the respiratory rate, and we're going to start to work with some advanced hemodynamics. And now I see the IDE ratio changing on the end tidal. If I keep adding some tracings, and I will eventually, it will get very crowded on the screen, but I've now added a pressure waveform. And a pressure waveform is specifically, this is an arterial blood pressure line. So a few things are happening to this arterial blood pressure tracing. And I'm going to remove some other tracings just to give us a better view. And some numerics as well. So you can see that there is auto scaling on the pressure waveforms. So the arterial blood pressure and the pulmonary artery pressures have auto scaling. So when there are major changes done to the pressure waveform, they actually do change the scale of this tracing window. If you are familiar with many of the cardiac monitors on the market used in hospitals these days, they also have auto scaling automatically enabled. Sometimes it can be a bit finicky in real life, and I've also brought some of that clinical realism into this device simulator. We may see that a little later. I also want to mention that the arterial blood pressure, as with any pressure waveform, needs to be zeroed. It needs to be zeroed to atmospheric pressure. And in a clinical simulation, if the student that is in the simulation does not request to zero the waveform, if you don't actually right-click it and hit zero transducer, you won't get a blood pressure reading. You'll only get the waveform. So this is very realistic compared to your average cardiac monitor that's currently in use in ICUs around the world. So as soon as I hit zero, it will, on the next vital sign update, populate with its numbers. And as you can see, if I actually switch this to a non-invasive blood pressure, you'll see that the arterial blood pressure updates with a pressure approximately every 2 heartbeats, every 2 cardiac cycles, with a little bit of variation, compared to the non-invasive blood pressure that does not update, much like an actual blood pressure cuff, which wouldn't update until you run the blood pressure cuff. So there's some additional realism built into this with about a if I remember correctly, it's a 1 to 2% variance that updates just so that the numbers bounce around just a little bit like they do in real life. Of course, if we wanted to actually introduce some variation that is clinically relevant, such as pulsus paradoxus or pulsus alternans, we can do that. So pulsus alternans, for example, is something that I can apply and keeps unapplying. There we go. So pulsus alternans, I've just applied it, and now the actual window, it's kind of struggling to auto scale because there's these rapidly changing beats, these rapidly changing pressures coming through. So if you notice, the auto scaling minimum and maximum numbers did actually change. There is a little bit of rough waveforms on due to the auto scaling feature. So I can toggle auto scaling and it does smooth out a little bit. I'm gonna disable pulsus alternans. Let's also take a look at pulsus paradoxus. So if I apply pulsus paradoxus, and of course with pulsus paradoxus, I'm gonna wanna compare this to a end tidal capnography so that we can see when the inspiratory cycle and expiratory cycles are taking place. I'm going to toggle auto scaling so that we can get an auto scaled waveform. And it's going to take about 5 to 10 seconds for an end tidal reading to actually show up. So earlier I edited the I to E, or inspiratory to expiratory ratio of the respiratory cycle. And you can see that that inspiratory and expiratory cycle does directly affect, when we have pulsus paradoxus, it affects the pulsatile waveforms. Sometimes the edges are a little rough, but clinically, the waveforms, they do all correlate to each other and they do all make clinical sense and clinical realism that we can teach our students to make clinical decisions based off of. I'm going to change the I to E ratio a bit, and I'm actually going to flip the switch for mechanical ventilation. Mechanical ventilation is an important thing for the patient editor to know to be able to translate what the intrathoracic pressure is for the patient model, this digital patient that's running in the background. So what we're going to see is, now that we've mechanically ventilated this patient, inspirations are actually going to increase intrathoracic pressure, which is going to actually flip the pulsus paradoxus because mechanically ventilated patients have higher intrathoracic pressure on inspiration, whereas for naturally ventilated patients, that's the opposite. So that actually does factor in to some of the calculations behind the scenes that Infirmary Integrated is making. Now, I just removed the mechanical ventilation flag, and we now see that when the patient's is holding their breath or has inspired, I'm sorry, uh, is expired, we have a lower arterial blood pressure, which we would expect due to that high intrathoracic pressure impeding the cardiac output. So all of these things kind of help show how some of the different parameters act on the patient model behind the scenes. Let's see. I'm going to now change the recording, restart a simulation so that we can look at some other features of Infirmary Integrated.